our featured speaker. Hi, everybody. My name is Jessica Goldman. I'm a member of the organizing team of North Seattle Progressives, and I'm the vice chair of Whole Washington, and really delighted to see so many new and old friends on this rainy day to help us take care of business and do what we know needs to happen for our state. Many of you have been involved with I-1600 for quite a while. Some are new today, some are new this week, and we welcome everybody. I-1600 is going to, with our good work, and it will take a lot of it, be on our ballot in November of this year. And we will be asking our fellow citizens to pass this initiative, which will ensure health care for everybody in the state of Washington, irrespective of employment, irrespective of income. It will be universal health care. And as we'll be learning in a little bit from Dr. Friedman, it's going to save us somewhere in the neighborhood of $9 billion in 2019. And he's going to explain to us how the math works, but it's tremendous. And for most of us who see how much of our healthcare expense goes to administration and not to providing high quality healthcare, it just makes sense. So both from a moral perspective and a dollars and cents perspective, this is critical for our work. We are doing this solely through volunteers. We have a team of about 500 people throughout the state of Washington and we're adding folks every single day. So if what you hear today sounds like something you want to get behind, there are folks over here at the Whole Washington table who can take your information and add you to our list. We have people everywhere. This is not just a Seattle group of blue liberals. We have people in every corner of our state who are supporting this and who are obtaining signatures. And at this moment, we're having trouble actually keeping up with getting enough initiatives to get them signed. We need 300,000 signatures by the beginning of July.
We can do it!
Yes, we can. We can do it together. And we are cash strapped, as any group of citizens and volunteers will tell you. And so every signature that we can obtain through our own elbow grease will be a huge contribution to our effort. At the end of the day, we will have to pay $3.50 per signature, which is a whopping number when you do the math. So all of us together hitting the road, we are confident that our work together can accomplish this. So I'd like to, before I introduce Gerald Friedman, just ask Senator Marilyn Chase if she would stand up. Marilyn Chase is a senator who represents... Senator Chase is the senator who represents this district, the 32nd Legislative District, and yesterday she endorsed our initiative, and we're thrilled for that to happen. And she signed it on our way in, so she's legit. So we thank her. I want to just, one more thing before I introduce Dr. Friedman. Typically, the way we work here at North Seattle Progressives is after we meet together, we break out into subgroups to kind of do the work. Today is going to be different because most of us plan on staying right here to listen to Dr. Friedman and to ask him questions for the whole duration. But we do have two of our subgroups, the environment subgroup and the Kremlin Gate subgroup, which will be breaking out. So, about half an hour, 40 minutes in, I'm going to just call a timeout and let those folks get up and walk out so that it doesn't feel weird and rude, but they've got business, really important business to take care of, especially as we finish the legislative session. So just know that will be happening. So we could not be more honored and thrilled to have Dr. Friedman here with us. This is kind of the capstone of a whirlwind weekend for him. He has been all over the state of Washington, literally, speaking to us, speaking to our communities and to citizens about his analysis and generally how healthcare economics works and doesn't work. And so he is a professor at UMass Amherst, and we're so honored that he spent all this time with us here. So let me just tell you a little snapshot about him. He received his Bachelor of Arts in Economics and History at Columbia University, and he received his PhD in Economics at Harvard University. He has been a professor at University of Massachusetts at Amherst since 1984, and he is the undergraduate program director there. He is an expert in the economics of healthcare, and he did the financial analysis behind Bernie Sanders' Senate bill and a bunch of other state efforts around the country. So he's the guy, okay? He's the guy, and we are delighted that he helped us figure out how this will work for our state. And he's also a great speaker. You're gonna really enjoy it. And after he talks about how he put this together, I know he wants to answer questions, and so we're gonna have as much opportunity as we can for people to ask questions and try to stump him, I dare you. So with no further ado, Dr. Gerald Friedman.
Okay, thank you so much. I'm reminded of a video of Bruce Springsteen and somebody, and this woman introduces the boss. It says all these things, and he gets up and he says, "Oh boy, I better be good now." But thank you so much for the generous introduction, and thank you everybody who's been hosting me around Vancouver, Spokane, and now here. It's my second trip. Sort of my third trip. There was once a conference in Seattle. My third trip for healthcare to Washington State. Everybody's always been very nice, and it's so beautiful out here in the Pacific Northwest. You have legal pot, and I'm really counting on you guys to get those signatures so that I'll have a reason to come again. I do promise you that if you get the signatures, I will come back. So, do it. Okay, so here to talk about, let's see, there we go. Okay, we found the problem. The problem with healthcare in the United States is big insurance. I just like the cartoon. Okay, where are we going to go? We're going to talk about America's healthcare. It's too expensive, and we don't get enough for what we pay. We spend a lot and we get little. How we got here, and this has to do with the economists. One of my favorite things in life is to dump on my fellow economists. UMass Economics was founded a few years before I got there. I was the last of the refugees from Harvard. Harvard fired a bunch of its radicals, and a couple of the others picked up and left. And they moved out in a block to UMass Amherst, and they established what we modestly consider to be the world's greatest heterodox economics department. Thank you. Yes. When somebody like Bernie Sanders is running for president, where does he go? He goes to UMass Amherst. So I got my picture in the front page of the Boston Globe through that, and Bob Poland was jealous, but okay. Okay, anyway, how we got into this mess, the market turn in healthcare, a better way, how whole Washington will work, and then how do we get there? Okay, so we got a lot of ground to cover, and with my New York accent, I'll go fast. Thanks. Okay, if you remember nothing else, then this is the graph. This graph shows life expectancy on the vertical axis and healthcare spending on the horizontal axis for member nations in the OECD, the Organization of Economic Cooperation and Development. At this point, if I'm talking to students, I'll ask them, I'll offer extra credit if they know where the OECD came from. But I'll skip that here, but you can Google it. Each diamond represents a country, and you see here that there is a positive relationship. This line is a regression line. It's a statistical measure of the association between these two variables. Spending, actually it's the logarithm of spending, and life expectancy. You spend more, you live longer. I mean, that should not be a surprise, except it is a surprise to most health economists. Most health economists, and I heard this from Richard Zeckhauser, who was head of the Kennedy School and was health advisor to Nixon, Carter, Reagan, Clinton. He came to a working group we had on historical demography, and explained that healthcare spending is a consumption activity like skiing, and it has nothing to do with health. Because people with insurance don't pay the cost of their healthcare. On the margin, you're not paying for your healthcare, so you just go for the hell of it. He brought up some fictitious grandma. Why is it always a woman? You notice that? Reagan, welfare queens, also fictitious. But some fictitious grandma who just goes to the doctor when she feels lonely. So she'll have somebody to talk to. Because after all, she's not paying for it. So what the hell? We abuse healthcare, he says. We just go for entertainment value, which is fine if you want to be entertained, but you should pay for it yourself. Just like, what the hell, I pay for my ski passes. Okay. It has nothing to do with health. We live longer, he said. And there's enough truth in what he said here that you can't dismiss it. We live longer because of better water and nutrition. And yeah, most of the increase in life expectancy over the last 120 years has been because of clean water and nutrition, but not all of it. You go from 76 years or 78 years life expectancy in Portugal to 82 years in France over here. Some of that is because the French spend more on healthcare. There's one exception, though, the United States. We spend the most. We're all the way out here. We're spending 50% more. Remember, this is logarithms. We're spending 50% more than any other country, but we don't get the life expectancy. You work out the numbers here. We spend $7,000 more per person than does Portugal for the same life expectancy. Or, if you use the regression line, we should be living 6 years more, given our spending. So at this point, I look at the audience, and I ask, do you want the money, or do you want the years of life? And it really breaks down generationally. All these young college graduates with debt, they're always like, like the people in that row there, they're always like, give me the money, I can pay down my debt. And then you get gray hairs like me. I want the years. Okay, but whatever it is, we should get one or the other. This is a measure of our inefficiency. And it's not inherent in the United States because it's gotten worse. It's become worse since Richard Zeckhauser was health advisor at HEW to Richard Nixon. I don't want to blame him totally, but it does kind of go back to 1971. 1971 was a big year in Canada. Anybody know why? They established Medicare. I probably don't need to tell a group in Washington that Canada is a separate country. When I was down in Florida a couple weeks ago, I said that, and a lot of people were like, oh, really? But okay, Canada is a separate country, but they still call their health program Medicare, just to make fun of us. Because their Medicare really does cover everybody, not just the elderly and the disabled. And it does offer good health care. And so we have 5 countries here, 5 affluent members of the Organization of Economic Cooperation and Development. I just averaged them out. Down here, there we go, okay, yeah. Down here, we have life expectancy and spending in 1971. And here we have life expectancy and spending in 2008, 37 years later. 37 years of universal coverage in Canada, 37 years of universal coverage, continued universal coverage in Great Britain. Okay, what happened? Life expectancy went up. They gained about 6 years, and they're spending a little bit more. If you work out the numbers, for every year of life gained, it costs them in 1971 $35. They're buying more life at that rate. And you could say, is it worth it? Is it not worth it? I don't know. But that's what it costs them with their universal coverage systems. Now, we also, and this is not clean water, and this is not nutrition. By 1971, we had pretty much 30 years of universal clean water, and most Americans eat well, and had been for a while. So we have all that by 1971. Now, we have, we gained 4 years life expectancy, not as much as they did, but not bad. Relative to the other countries, notice we've lost ground, but still we're okay. We gained 4 years, but it cost us $1,000, $250 per year of life gained. Maybe that's worth it. I'm not saying whether it's worth it or not to gain a year of life expectancy by spending $250 more per year. But it is a lot more expensive in the United States than in other countries to gain life expectancy. Our system is economically inefficient. And it's not just because we're the United States and they're Canada and France, because we've lost ground. We were the United States in 1971, we're the United States in 2008. By the way, what's happened since 2008 to life expectancy in the United States? It went up a little bit for a couple of years, and now it's going down. And we're going to talk about that in a minute. Okay, here's the problem for Washington State in particular. This is a share of income in Washington State going to health care. This goes back only to 1991, and it goes up. It leveled off under Obama. I could give a whole talk about that, and that's really interesting. To be sure, everything that the Obama administration did to control healthcare costs, it's going away. The CMS, Center for Medicare and Medicaid Statistics, expects that healthcare spending will go back to its old rate of increase of about 5% a year. Projecting that for Washington State, you expect that your healthcare spending in another 10 years is going to be about 17% of your gross state product, up from 10%, up from 14% now. Between 1991 and 2018, you had to dig into your pockets and find 4% of your income, take it out, and put it into the healthcare budget, with very little to show for it. Over the next 10 years, you're going to have to dig back into your pocket and find another $4,000, another 3% of your another 3% of your state income, and put into the healthcare budget. And this is what it means per employee, per working person in Washington State. Since this only goes back to 1998, from 1998 to 2016, wages are $3,000 lower on average because health care costs, premiums on health insurance plans, have risen faster than the consumer price index. So after taking account of inflation, employers go to you, your employer goes to you and says, you know what? Healthcare is costing me more money, so I wish I could give you a raise, but I'm sorry, I can't. I would like to give you a $1,000 raise, but I'm taking that $1,000 and I'm putting it into your health insurance. And that's not even counting that you're paying more, and you're paying more for copays and deductibles. Now, why do we have this problem? Why is our health care so expensive? It's not because we use too much. Zeckhauser's fictitious grandma is not only a sexist thing to say, but it was just plain wrong. We don't use too much health care. We use less than everybody else. It's like the average for other rich countries is 7 doctor visits per year. For us, it's 4. Mexico, Turkey, relatively poor countries, they go to the doctor 6 times a year. They can afford to go to the doctor 6 times a year, but we can't. something weird about that? Of course, the health insurance people and flax for the drug companies, they'll all talk about, oh, we have the best healthcare in the world. And well, probably we have the best doctors, the best hospitals, the best technology, but it doesn't do you a damn bit of good if you can't afford to go to a doctor. And that's what's happening in this country. And that is the deliberate policy coming from people like Zeckhauser, who thought that healthcare was just a waste, that we were abusing the system. We're not abusing the system. You know who abuses the system? The Japanese. They go 13 times a year. And you know what? They have the longest life expectancy in the OECD.
Imagine.
Okay. So instead of going to the doctor all the time, or you could say, well, why don't we go to the doctor? We don't go to the doctor because we have cost barriers to going to the doctor. Co-pays, deductibles. A third of Americans report that they did not do something last year because it was too expensive for them. Double the rate, more than double the rate in other countries. Why didn't they fill a prescription? Why didn't they go to the doctor? Well, oftentimes they go to the doctor, they get a prescription, but they don't do the follow-up visit. Or they do the follow-up and they don't go to the specialist that the doctor tells them to go to. Or they go to the doctor and the doctor says, well, I'd like to do some tests. And they say, oh no, that's a separate copay, I can't afford that. Yeah. A third of Americans are in that situation. Here's what's been happening to your deductibles. I don't need to show this. You know this. My wife knows this. She poured out, by the way, if you thank me, I do appreciate your thanks, and I much enjoy it. My wife's really the one. This is my third healthcare talk visit away in the last 6 weeks, and she's like, you're going again? She believes in the cause, and this is her contribution. But anyway, my wife once poured out her pocketbook. This is like 2 years ago. And, it was getting heavy. Maybe you've experienced this or seen this. So she poured it out on the kitchen table, and she found all these old health insurance cards. Now, we haven't changed our policy for 25 years. So why do they give us a new card every year? Doesn't that seem like a waste? Yeah, but she lined up the cards chronologically. She found 8 cards. And she said, you know what's happened to our copay? Every year it went up $5. So it's $50 now. So a couple days later, I was feeling, throat hurting and things. And it was a Friday. I knew the doctor wasn't going to be around over the weekend. I thought, oh, maybe I should go have somebody look at it. Maybe it's bacterial. They could give me a, penicillin. And she said, well, Jerry, it's a $50 copay. I tried not to take offense. Am I worth $50? But okay. Okay, so the deductibles have gone up, the copays have gone up, and as a result, people, the most basic thing, they don't fill prescriptions. This is the one that really gets me from the Commonwealth Fund, their survey. The doctor gave you a prescription, identified a problem, and a solution. It's not just like the doctor said, oh, well, you've got this thing, and you know what, there's nothing we can do, just go die. No, the doctor said, you can fill this at the pharmacy, and this will help you. Well, guess what? 15% of Americans with health insurance, 14% of Americans with health insurance did not fill a prescription. Sometimes, and I don't know, this may be even worse, and I know people who do this. You probably all know somebody who's done this. They stretch it out. Yeah. They're taking blood pressure medicine. They can't really afford it. So, well, maybe I'll just take half of it every day. Or, well, I'll take the antibiotic till I'm feeling better, and then I'll save the rest for next time. Oh, great. Not only does, often it works. Often you'll be okay. But sometimes you won't. And other times, all you're doing is making a public health hazard for the rest of us by breeding antibiotic-resistant bacteria. So, okay, that's 14% of those with health insurance did not fill a prescription. 33% of those without health insurance. having health insurance helps. But even Americans with health insurance, even rich Americans with health insurance, often skip medical procedures because of the deductibles and the copays. We ration care. They'll tell you, these flacks for the insurance industry, they'll tell you, oh, you pass universal coverage and you'll be rationing care. Yeah, let me tell them, we ration care already. And who has the insurance that actually covers them? Now these graphs are from a study by some people at Brookings using data from the Social Security Administration. You know, the Social Security Administration knows a lot about you. They know how much money you earn in wages every year, you know, with a cap, so it's not perfect data, but, and they know whether you're alive. I mean, okay, they make mistakes. They once declared my mother-in-law dead. You know? Well, we had a lot of fun outside the apartment with that one. But I think they took my mother-in-law's experience and they made a TV show episode about it in Frankie and Gracie with Lily Tomlin. Oh God, I want to marry Lily Tomlin, but I kind of sometimes I feel like I already did. So, but okay, anyway, for men, what they do is you look at men at different points, 20 years ago and now, and their life expectancy and their income at age 55. So for men, we've got, this is 20 years ago, and this is now. Life expectancy's gone up, and here's income. So it's gone up the most for the rich people, but even for poor men, it's gone up a little bit. That's pretty good. You know, it's like, you know, you might say it's not fair that lower income, middle income people don't live as long and haven't gained as much as richer people, but that's just part of American inequality these days. At least everybody's gained something. That's not true of women. Look at the women. The lines cross. Nowadays, poor women, and when I say poor women, I mean 40% of women.
Wow.
Not just 10%, 20%, but stretching up into the middle class. 40% of women have shorter life expectancy at age 55 than they had 20 years ago. The first time I presented them, I had to confess that I had looked at the data, but I hadn't separated out the genders. So the men's experience kind of eclipsed the women's. So that was just my bad. But these guys, they separate out men and women. But I said, how could this be? Afterwards, a woman, this is down in Oregon, came up to me and said she worked at a food bank. And she understood exactly. When a family doesn't have enough money, who doesn't eat?
Mama.
Mama. You don't have the money, whose prescription do you skip?
Mama.
Mama's. You're not going to take a prescription. If your kid needs it, no. Yeah. So these poor and lower middle income women, they're the canaries in the coal mine telling us not only the consequences of inequality and cutbacks in welfare, repeal of AFDC, and all those things, but they're the canaries in the coal mine telling us what happens when we ration health care by income and by the price system. And this tells you more about it. Americans die because they can't afford health care. What doctors do makes a difference. You know, if you're an MD, you can pat yourself on the back. Contrary to what many economists say, you actually save people's lives. Yeah. And when people can't go to you, they die. Each dot each diamond is a county, 3,000 counties in the United States. The vertical axis is the mortality rate in the county, and the horizontal axis is the proportion of people who report they could not afford to go to the doctor because of cost.
Which counties?
Every county in the United States. I have Washington on the next slide. This is every county in the United States. And this is the regression line. Guess what? Upward sloping. Statistically significant. if you can't afford to go to the doctor because, of course, you're more likely to die. Here's Washington. Upward sloping, almost exactly the same regression equation. Kind of interesting. Washington is a good sample of the United States. There's every county in Washington. Counties where more people can't afford to go to the doctor, more people die. We're talking about thousands of extra deaths in Washington. I think the number was like 8,000 extra deaths in Washington each year. Here, we're looking at just the poverty rate. The counties with a higher poverty rate are the counties where people are dying. There shouldn't be any surprise. Who is going to be locked out, rationed out of the healthcare system? The poor and the middle class. Working people and people in poverty are the ones who are going to be unable to go to the doctor when we raise prices. Actually, people eligible for Medicaid are kind of in between, because nominally they have health insurance, but it often doesn't actually, get them access because of the way Medicaid prices things. Okay, rationing by income. If it controlled costs, if it was saving us money as a country, then you might say, okay, so we die more often, but we're saving all that money so we can go skiing more often. I really like to go skiing, so, I might say, okay, I'll give up a couple years of life expectancy, especially if it's somebody else's. But no, it doesn't even work. I mean, it's not even an issue. Here I just have particular drugs for 3 countries. You could do this all day. And there are people, this is what they do. They compare prices. And you know what? They always find drugs are more expensive in the United States. Here's 100%. That would be where drugs are the same price in the United States as in other countries. Every case is above 100%. We could find your drug if you want. Let's see. Here we have Celebrex for pain. In Canada, it's 4 times as expensive in the United States as in Canada. It's twice as expensive in the United States as in Britain and the Netherlands. So you want to buy your Celebrex in Canada. It's the cheapest there. Other drugs you may feel differently. Like here's Cymbalta for depression and pain. It's 80% more expensive in the United States than in Canada, but it's 4 times as expensive in the United States as in the Netherlands. So it's 25% of the price in the United States in the Netherlands. You want to go to the Netherlands to buy Cymbalta. And then there's this one, Nexium for acid reflux. I once had a prescription for that. It costs almost over 9 times as much in the United States as in the Netherlands. I mean, most of you probably don't get your entertainment by reading the economic report of the president. But this year, first of all, it kind of had slipped my mind that he actually found economists, but he did. And they put out an economic report in which they note, the focus of it is on drug prices. And they note that the markup on drugs is 80% in the United States, but only 20% in Europe. So they're admitting that drug prices are a lot higher in the United States than in Europe. But that's a problem. The Europeans are getting drugs too cheaply. We should beat up on them to push up the price of drugs so that our companies can make more money. Okay. Here's medical procedures, so forget the drugs. But next time you need an angiogram, go to the Netherlands. It's only going to cost you less than 20% as much. And then, while you're there, get a CT and an MRI. Maybe do an appendectomy while you're there. All the money you save, you can stay in Amsterdam for weeks and weeks. There actually are tours you could get where you go to a place like Madrid, get your hip replacement, And with the money you would have spent in the United States, you stay there for a few months, do the PT and all, and visit the Goya museums and, travel around. After all, your hip will be feeling better. And you should, after getting a hip replacement, you should walk a lot. It's good for you. Yeah, right. Okay. So now, why is it so expensive? Part of it is, as we just saw, monopoly pricing of drugs, and monopoly pricing of hospital services. Now, I told this story in front of the head of Massachusetts General Hospital, and he came up to me afterwards to yell at me. But he couldn't quite deny that the story is true. The story is told to me by the former head of emergency services at Cambridge Hospital in Cambridge, Mass. And he says that if you get hit by a car in front of his hospital and you get brought in to do they'll do an MRI. When they ship you over to Mass General, if they ship you over to Mass General, they'll do the MRI again, which first of all is a waste, and they'll charge you 4 times as much for it. The guy at Mass General was like, we look expensive only compared to other hospitals in Massachusetts. We're no more expensive than Yale Memorial. Yeah, okay. Yeah, okay. Anyway, monopoly pricing of drugs and monopoly pricing of hospitals. That's a big part of it. But another part is, we pay for hundreds of thousands of people to market health insurance to us, to sell us a product, and then hundreds of thousands more to, when we try to use that product, tell us no way. We pay these people, they call them utilization review. Doesn't that sound nice and benign? Utilization review? That's kind of like, did you drink your 3 cups of coffee in the morning or something, It's like, no, utilization review is the person at the other end of the phone who tells you or your doctor, no.
Yep.
And they love saying no. They're like toddlers, It's like, okay. But it makes rational sense, which is why we should give up on using the market system. Healthcare should not be treated as a commodity, and health insurance should not be run by for-profit companies.
Yeah.
Oh, okay. Good applause line. Yeah. When I was growing up, my father ran a coffee business. And his thing in running his coffee business was to make better coffee so that people would want it, and for lower prices so that people would buy it. And the more he sold, the richer he became. That is the opposite of what happens in health insurance. And the reason is, I used to call it the 70-10 ratio, but I decided I need to be more accurate. It's the 66-10 ratio. 66% of your healthcare costs are incurred by 10% of the people. 50% are incurred by 5% of the people. The most expensive 1% of the population, the 1% of the population that uses the most healthcare, spent over $135,000 last year. 30% of the population spent like $200 on average. 50% spent $200. 30% spent nothing. Yeah. Well, how did they spend nothing? Well, they were healthy. They never went to the doctor. We had to really nag younger daughter Tasha. She was visiting us for a while in between doing hippy-dippy stuff in Mexico and now Arizona. So we had to really bug her. Go to the doctor while you're here. And while you're here, go to the dentist too. So, she did. She's compliant. Yeah. So she spent something. But otherwise, she wouldn't have spent anything. She's 27 and healthy. Yeah. 30-year-old Rosa, we had to bug her to get a primary care doctor because she said, I'm busy and I'm healthy. But what happens when you get by a car? What happens when you get cancer? Well, what happens if you have a baby born prematurely? My sister's sort of stepdaughter had twins born at like 26 weeks or something. It's like the outer limit of survivability. Each of them was over $1 million. They're both fine, by the way, which is kind of like, except that kind of mom and dad are neurotic. The Ashkenazi Jews. Okay, anyway. Oops, back. Okay. So, now, since you know that 10% of your people are going to be the really expensive ones, and you know what? Over a third of that 10% are going to be the most expensive people next year also. If you are really sick one year, chances are you're going to be sick the next year. No surprise. If you have cancer one year, you are more liable to get it again next year. And even if you're not really, in the most expensive category, you are going to be expensive. And if you're very healthy and young this year, I can see some people in the audience, I bet you haven't gone to the doctor for a year, and you're not going to go next year either. You're fine. But, so, what do you do as an insurance company? You find the people who are going to be expensive, and you figure out a way to get them to go away. A universal system can't do that. A national or even a state system, basically you're stuck with the people, so you have to try to figure out how to keep them healthy. But a health insurance company, Blue Cross Blue Shield, Kaiser, any health insurance company that wants to survive, that wants to make a profit, that company is going to try to find those sick people and drop them. They call that lemon dropping. I am a lemon. I'm not a bad lemon. I'm almost sort of sweet, my wife says. But I do take 3 drugs every day. And I have sleep apnea. I carry around this device. She calls it my trunk. And it really helps. I wake up feeling much more refreshed and all good. So I'm not the most expensive, but these things add up, And given blood pressure, cholesterol, and thyroid, given them, the chances are, one of these years I'm going to, plus I ski and I have a bad habit of running into trees. So, they want to drop me. Now, I'm looking at this audience. I mean, there are those people in that row over there, the young women. They are the cherries. You want to pick the cherries. Get them to buy up your policy. Because after all, they're not going to spend a lot of money. I mean, something may happen to them, but chances are, I certainly hope not, but chances are they'll be low cost. And how do you do that? Well, you get rid of me by utilization review. Every time I want to do something, I got to go file, and my doctor has to talk to some quote-unquote snot-nosed in Omaha. That's what, a doctor once told me. I have to talk to some snot-nosed kid in Omaha who knows absolutely nothing about my patients, who's telling me how to treat them. And then you get this guy here by offering gym membership, free sneakers, maybe a season pass to a ski place or something, No, they don't want to do that, but, yes, season pass to someplace healthy. Oh, a pool. That goes with the gym membership. Yeah, you offer them that, and it's like, hey, yeah, I'll take your insurance. Yeah, and after all, the cherries don't even know about utilization review because they never run into it. It's the sick people who find out about that, and then they change insurance companies. Let's say, on the other hand, you're nice. You just treat everybody, you treat them like the National Health Service. Here are your prescriptions, what else can we do for you? You know what? You're going to attract every sick person. And your insurance company is going to go bankrupt. You'll have to raise your rates, and the young, healthy people are going to say, oh, that's too expensive. And I never need it anyway. And they don't offer gym memberships. Yeah. So this is what the for-profit system does. It destroys health insurance. Okay, we have a better way. Fortunately, we have a better way. And the thing is, you may have seen last week the Center for American Progress, this group of liberal economists who 2 years ago got my wife really mad because a bunch of them attacked work I did for Bernie Sanders. Which is kind of Like, come on. You know, Alan Kruger went to grad school with me. He had my email. And Christine Roma, we're friends again. But we were friends in grad school. She wrote that nasty letter about me. Anyway, these Center for American Progress people, they came out with a Medicare Extra plan. Their own universal coverage plan. Though it's not quite universal, but actually it would be pretty close to universal. It's pretty good. I tweeted about it, welcome aboard, because after all, guess what? All the assumptions that I made in my work for Bernie and my work for you, they accepted them. All of a sudden, they realized, hey, health insurance is inefficient. All this administrative waste, all this utilization review, we don't need it. Health insurance companies actually add no value. Okay, here are my estimates of the gross savings. That is the amount of money that people in the whole state, people, businesses, governments in the whole state will save. And you can break these out into several categories. The gross savings, total amount of savings, not taking account of extra expenses associated with this plan, come to about $16 billion, which with a population in Washington of 7 million means over $2,000 per person in savings. This is a big money. The biggest area of savings is in what I call provider administration. Now, if any of you are a physician or any of you work in a hospital, you know that a lot of the money that you pay a physician actually goes to what they call BIR, billing and insurance-related expenses. On average, every hospital in the United States, on average, has one person doing BIR for every bed. Yeah.
What a waste.
Yeah. So every day, there's one person who spends the day and is paid for the day to work out the bill for the bed for that day. Work out the bill, talk to the insurance company, maybe more than one company. If you're a senior, you have Medicare, and you probably have a wraparound, and you have a Medicare Part D drug plan. And maybe, if you're like my mother-in-law, you have another insurance coming out of your work, retiree health benefit. So she has 4 separate insurances. And when she goes to the hospital, somebody in the hospital administration has to work out, first of all, how much to bill her for that day. And remember, each insurance company will pay a different amount. And then who's going to pay what? And then she has to argue with the insurance companies about how much. Now, a few years ago, I was testifying in Boston, and I cited an old study that Toronto General Hospital in Canada, separate country, with real Medicare, Toronto General Hospital had about the same number of beds, about 400 beds, as Massachusetts General Hospital. About the same number of beds, same number of patients, same number of physicians. Toronto General Hospital had 2 people doing billing. One person who billed people from the United States. Massachusetts General Hospital, I said, had 250 people doing billing in the mid-1990s. 250 people doing billing. Afterwards, a legislator came up to me and said that she had been texting with her husband, who's a manager at Mass General, and didn't want to be quoted by name, but there are 450 people doing billing now.
Wow.
Yeah. So if we reduce that to a number comparable to Canada, which is a very low number, you save $5.5 billion in Washington State. Almost $1,000 per person. Okay, then we've got another $5 billion, 5,000 millions, which is the extra cost of the insurance industry. Yeah. So this is the person in the hospital or the provider's office who calls the insurance company. And here's the person who answers the phone in the insurance company. Although it takes a while. I've talked to many people about this. My family physician had gone to college with me. So I'd talk to him about it. And he would also tell me things that he said would not to be cited by his name. But anyway, he did have 2 people in his office, one a registered nurse, who basically spent the day talking to the insurance company. And one thing that would add to the cost, that would make it harder for them to do it, is they'd call and they'd get robo-menu. It's just like you're calling the cable company. The insurance company, it might take 15, 20 minutes before you get to a person. And all that time they're listening to this god-awful music. Now, why do they do that? Let's see. If you never get through, then they will never have to say no, and they will still never pay you. So they go through all that. That's $5 billion for the extra expense of the insurance company. Not only the billing side, but also the marketing side, and the profit side. And apart from the profit side, take the 10 largest health insurance companies in the United States. Their CEOs are paid last year about $200 million, $20 million each. The head of Medicare and Medicaid services provides health care to the entire United States, paid about $250,000. Yeah?
So everybody in the 5.2, that side.
5282.
The person who actually does end up answering the phone, if they can turn it down, then that adds to their bonus.
Oh.
At the end of the year.
Yes.
Can you repeat the question? Jim?
Okay, yeah. It was an observation that the insurance companies give incentives to people to turn down claims.
Yeah.
The person who answers the phone not only says no because that's on the script, but they continue to say no, knowing that if they get through saying no, they will get a bonus.
It's capped.
Yeah, for denying you care. Okay, so we're up to $10-11 billion. There's another $3.5 billion if we paid drug companies what the Canadians and the Europeans pay on average. Now, mind you, that is actually 4% more than the VA pays. The VA actually negotiates prices, drug prices. The VA is about the size of Washington State. They negotiate drug prices, and they pay 41% less on average than do the rest of us. The Canadians and the Europeans, as of a few years ago, paid 37% less on average than we do. I think that number, probably using the data in this economic report of the president, I should update that number. But, it would be bigger now. Okay, yeah, one question, then get back. Yeah.
What's the time period?
Oh, this is annual. What's the time period? These are all annual data. This is actually my estimates for 2019. So this is if you enacted this in November and you implemented it on January 1st, 2019. And everything went through smoothly. It's like, okay, it's not going to happen like that. But this is, at least, a good order of magnitude. Okay, so up to about 14 billion. There's another 1.5 billion that I estimate you get through fraud reduction. You have one agency handling all the bills. There's a lot of dispute about how much fraud. I'm putting 2.5% could be gotten out of the system. Other people actually use higher numbers. And then there's 622 million on there because that's what employers in Washington pay to find an insurance company and to negotiate with it. Your employer pays money to hire consultants, hire insurance agents, so they can find an insurance company. Why? You don't hire somebody to find Social Security. But okay, so we'd save 622 million more there. Now there are expenses. But I prefer to call them quality improvements. It's wrong to talk about these as just expenses. We have to pay this extra money. The billing and insurance stuff, that's an expense because it doesn't provide any health. But there are things here that are real improvements. For example, universal coverage. Washington's pretty good. You have Medicaid expansion, you have a well-functioning exchange, so you're pretty good. But there are still 300, 400,000 people in the state who don't have health insurance. They would be covered here. That's good because they'll have access to health care. But guess what? That's going to cost money. I estimate about $1.3 billion. We're going to do away with copays and deductibles. And guess what? People will start going to the doctor more. I mean, that's part of the idea. People will be able to get better health care that will help them be healthy, productive, happy. Maybe that's too much to ask, but because he'll still be in the White House. So, okay, but that's going to cost, I estimate, $3.2 billion. A real significant bump up in healthcare spending. $1.9 billion because when you're providing universal access to everybody, guess what? You can't charge seniors for Medicare Part B anymore. I mean, why would anybody pay for Medicare Part B if they're getting access anyway? So, that's going to have to be picked up by the whole Washington program. And then $680 million because when you're covering everybody in one system, you can't discriminate against people who are providing care to people on Medicaid. So doctors providing care for Medicaid people will have to be paid the same as everybody else. And then there's some other program improvements, including unemployment insurance for people who are displaced. I'm assuming 2 years of unemployment insurance plus job retraining.
Yay!
Yeah.
Okay.
Don't worry, most of them will get jobs pretty quickly because
Yeah.
we'll be providing, there'll be more jobs created, but we'll come to that. Okay, spend money on healthcare, not administration monopoly prices. Right now, only 66 cents out of every dollar that goes into the healthcare system actually goes to healthcare. The rest goes to monopoly profits to the drug companies, some monopoly profits to hospitals, goes to billing and insurance in provider offices, goes to the insurance companies, all various forms of waste.
Will you repeat that number again, please?
Only, 34% of what is spent on healthcare goes to bureaucratic waste and monopoly profits now. Administration and monopoly profits. Not all of it is waste. You still have to have somebody in the office who does scheduling. There'll still have to be somebody in hospitals doing HR. There'll still be some administrative activities, but a lot of it will go away. 66% now goes to healthcare. Under the Washington program, under I-1600, 82% will go to healthcare. You'll be putting money into healthcare, and 82% of it will actually go to healthcare. Some will still go to the person who does scheduling. You need that. You need somebody to do HR. You need somebody to cut the checks, to deposit the checks, and all that stuff. There'll still be administrative tasks, but most of them will go away.
Would the fraud protection be there? Because that's what a lot of people.
Yeah, fraud. Well, there's question about fraud protection. Yes, we will have to have fraud protection. I'm assuming you're going to be getting rid of some of the fraud in the system. Utilization review is often billed as fraud protection by the insurance companies, but we know that mostly it's not. Okay, I'll take questions more. I'm almost done here. Okay. Some will benefit more than others given the tax program that, I hope I can get away using that word here. But given the tax program that we're talking about, we'll be shifting from a system where everybody pays the same amount for health care regardless of their income. But the sick pay more. We'll be shifting from that system to a system where everybody will be paying according to their income without regard to their health status.
All right.
So if you're born sick, if you have a child who's born premature, if you just get old and sick, if you're an idiot like me and you ski into a tree, you could say, okay, Friedman, you should pay for that yourself. But okay, I paid in pain, I assure you. Anyway, right now, I pay the same for health insurance as does the chancellor at my university, and he earns 4 times as much as me. He probably earns 8 times as much as me. And, I'm not complaining, I earn okay. But the department secretary who kind of Xeroxes my quizzes and things, she pays the same amount as I do. And that is probably equal to her whole salary.
That stinks.
Yeah, it stinks. Yeah, and if she got sick, she pays the same copay as I do, which is why the poor don't go to the doctor and why the poor die. Okay, the effect of this program, the poorest people won't be affected financially because they're not paying, if you're on Medicaid, you're not paying for your health care, whatever you get now. The richest are going to pay more.
All right.
Yeah. But, mind you, a 6-7% reduction in their net income because of this program, they also will be benefiting by universal access without copays and deductibles. They'll benefit because their children, who may not have as much money as them, they'll benefit because their neighbors will be healthier and will have less communicable diseases. Everybody will be benefiting. They'll be benefiting because their workers are healthier. And then you get to the working middle classes, that's where the real benefits go. Because those are the people where a $25,000 family plan is a huge burden.
Amen.
And those are the people who won't be paying that much on income-related taxes. Okay, other benefits, medical bankruptcy. In the state of Washington, I estimate that there's about a 10% chance that a random person will go bankrupt at some point in their adult life because of healthcare bills. You go to the hospital, you get taken in an ambulance, you get checked in, and before you know it, you've run up huge bills, and half of Americans don't have $4,000 or $5,000 in financial resources available. Most Americans below the 20th quintile are, financially strapped. Whatever wealth they have is in an immobile form in real estate equity. Most Americans can't pay a $6,000 deductible without running it up on their credit card. And you do that a bit, and you know what happens? Pretty quickly, you are in big financial trouble. So about 6,000 to 7,000 medical bankruptcies in Washington state every year.
But what about the poor credit card companies who won't be able to charge interest?
The poor credit card companies that won't be able to charge interest. Well, you know what? The banks will benefit because they don't like it when people go bankrupt. They actually don't like having to write down debt. If they lend you money and you go bankrupt, they don't like that. They're losing. So even the banks will benefit a little bit. Net increase of employment of about 100,000 because businesses in Washington state won't have to go around paying for health insurance. And small businesses won't have to worry about, because it's small businesses that pay the highest premiums, but also small businesses have the most variable premium. One person in your 10-person staff gets a major bill, and next year your health insurance rates go up. Yeah. So small businesses will benefit disproportionately here. And then we'll lower the premature mortality rate by as much as 12%, saving 7,500 lives. How much is 7,500 lives worth? Is it only an economist who would ask that question?
Yes.
The first thing is, well, what's that worth? It depends. using the number from the EPA, that's worth about $75 billion. Using the number from the Department of Transportation, it's worth only $37 billion. If you die, you want it to be on the EPA, not the transportation. Okay, this is obviously impossible. This is available, and when they put out the report, then this table's there. Revenue sources. We start with, well, actually, we go back to here. Total spending under the current system would be about $80 billion, $16 billion of savings, $7 billion of program improvements. That gives you, we have to come up with $71 billion to fund this program. Does that sound like a lot of money? It is. Yeah. But, 71 billion, you're already spending $42 billion on Medicare, on Medicaid, there'll still be some out-of-pocket spending, not much, because I'm assuming an actuarial value of 96%. But, when you go to the drugstore and you buy Band-Aids, you're still going to have to pay those yourself. When you buy aspirin, that's going to be on you. And that adds up. Yeah, it already is, yeah. So we're not doing away with all the out-of-pocket. So, we're starting out with 42 billion. That's a pretty good start. We need 28 billion. We get the largest part with an 8.5% payroll premium. The first $15,000 is exempt. That's really important because right now, really low-income people don't pay for their health insurance because if they're on Medicaid. So we don't want to suddenly start sticking them with a big bill. I mean, after all, they're the ones who couldn't pay it anyway. So we got 18 billion. Payroll premium on partnership income. You're a lawyer and you're getting your income as profits, your share partnership profits. Hey, that's wages to me. So you have to pay on that. Okay, yeah.
Is that 8.5 paid by the employer or the employee?
They have a formula. I don't pay attention to that formula because ultimately it's all paid by the employee. Ultimately. The same for technically Social Security, your employer is paying half. But what your employer is paying is money, it's coming out of your pocket eventually. But it is paid by the employer in the bill. Yeah. Don't worry, the employer will find a way to lower your wages so that you'll pay for it. But that's, I think that point's important because right now, I would say, and I think 100% of labor economists would say that premiums, health insurance premiums, the share paid by your employer, that's coming out of your wages. You're paying for it already. You don't realize you're paying for it. Your employer may be putting in $22,000 a year for your family plan, which is the case for me, and I put in $5,000. But that $22,000 is not available for wages. So it's really coming out of me. Okay, anyway, the employer will pay 8.5% with $15,000 exempt, then a sliding scale, that exemption goes away. Capital income will be taxed, capital gains. There's a $15,000 exemption there, but don't worry about that. Almost nobody has less than $15,000 in capital income. Because if you have capital income, you're really rich. Something like 90% of the capital income goes to the top 10%, which means it's big numbers. And they're going to be paying something on that too, just like wages. There's a 1% flat-off income tax with a $15,000 exemption. So that, I believe, passes constitutional muster in Washington because it's a flat tax. Steve Forbes would like it. Then there's a premium that's only above 200% of the poverty line, and then it's a sliding scale from 200 to 300% of the poverty line, and that premium rate is set at the rate of Medicare Part B. Altogether, we get $29 billion, which means $1 billion more than we need. Yeah. The more important than whether it's the $1 billion surplus the first year is over time,
you will be saving more and more money. Because remember, the things that increase in healthcare, drug prices, monopoly prices for hospitals, administrative stuff, that stuff has all been increasing faster than everything else.
Right.
So when we control those, we slow the rate of growth of healthcare spending. Which means that the share of GDP, the share of your income that goes to healthcare will actually level off. Instead of having to dig deeper into your pocket to find extra money for rising healthcare spending, you'll be pretty much stable at 14% of gross state income. So this is a plan that's not only works now, but works more and more in the future. While what you're doing now in Washington is unsustainable because it means rising share of income. Now, how are you going to get there? When I was a kid, my hero still, in this picture, Eleanor Roosevelt, Franklin Roosevelt, I'm showing my age, and Sidney Hillman. Some people know who Sid Hillman is? Yes, sort of. Founder of the Amalgamated Clothing Workers, the Jewish Labor Bureau, and the CIO. Also, he talked to Franklin Roosevelt. And he worked closely with Francis Perkins, who was Roosevelt's Secretary of Labor. After the election, he brought a memo to Roosevelt with a list of, okay, this is what you do. We're in the middle of a depression. We got all these problems. Here's how you fix them. Roosevelt looked at it. FDR looked at it and said, okay, I agree with you. I want to do it. Now make me. You know, politicians don't lead, except for the state senator. But politicians don't lead. Politicians follow. You know, the politicians we like are willing to follow us. But, you know, you get elected because you are very careful. Yeah. They need to know that there are people out there, and it helps if you push them. That's what Hillman did. That's what the CIO did. That's what the civil rights movement did. You know, John Kennedy, he didn't want to do the Civil Rights Act of what became the Civil Rights Act of '64. He had to be pushed into it. I mean, he thought it was a good idea, but it's like, okay, I don't want to have a fight with the Southern Democrats. You know, he did it because there were the protests in the streets and they needed to respond. That's how you're going to get health care in Washington State. You're going to do it yourselves. You know, they're going to dump a ton of money on you. They're going to buy every ad space in Seattle, Spokane, Portland television. I mean, they will put whatever money they feel they need. And you'll beat them by talking to your friends, by organizing. Your people power will win over their money power. Thank you very much.
Okay, we're back here for the question. Say your name.
My name is Gordon. I was just wondering on the provider side what it looks like. Is it still just the regular HMOs, Polyclinic, Kaiser, or is it a state-run medical facility, kind of like a VA?
No. The answer is no to both of those. It would not be an HMO. There would be no utilization review conducted by the state board, and doctors would not be employed by the state, as in the VA or the National Health Service. This is straight private enterprise doctors and hospitals, but the bills would be paid by the state.
Back here on the right.
Hi, my name is Gerald. I wanted to know, going forward, how would we, you said like talking to friends, of course, and friends and family, but who is, or how can we talk to employers and so forth, because I'm not clear that they understand that they would save money.
Yeah.
Do they understand that?
Oh, I doubt it. I doubt that they understand how much they'd save. And, you know, that's what you need the whole Washington and all of you to be organized to go out and do that. The employers would save. Also, another huge saving would be if it's local governments, because local public employees have a very high take-up rate on their health insurance. That is, 90% or so actually get health insurance through their employer, whereas that's only half of private employees. So health insurance is more expensive for state and local governments. So if you bring it down to 8.5%, they'd save a lot of money. Your local government would have the money to fix the roads.
So Garrett, I think I just heard you volunteer to join Whole Washington to help us with our effort to talk to employers. Thank you.
Well, I'm Donna Scar from Blaine, and I had two questions. People who were signing my petitions are saying, I won't sign your petition because I'm not going to have to give up my Medicare card. Now, you just said Part B, but they're not going to give up the whole card, are they?
Well, no, the card would be redundant. They'd still have a Medicare card. Technically, the way it would operate is they would be enrolled into a Medicare Advantage plan run by the state that would provide universal coverage. Anybody on Medicare will get better coverage, period.
But they can still carry their card.
They keep that card, yeah.
Okay.
Yeah, they would keep that card, but the point is, the important point for them is they would continue to get benefits. And in fact, they would get better benefits.
Something that I did not see as I went through the 47 pages was reference to the current master charge lists, charge master lists that hospitals have, that they negotiate with individual insurance companies. This would automatically...
That would go away. They would, for starters, they would use the master charge list that they negotiate with Medicare.
Richard.
This is, I think, continuing on that same issue in terms of cost controls. Last year I had a medical incident. The bill was around $48,000. When Primero was done, they only allowed $12,000 of that. Yeah. Now, my assumption there is that actually was enough to cover the hospital's costs. Mm-hmm. So, if I understand, you're saying that the state is somehow going to rewrite and negotiate all of these costs down to somewhere around that level?
Well, if you had, if they had charged Medicare rates, the price, hospitals have this fictitious price list, and nobody pays that, because the only people who would pay that would be people who don't have any insurance at all, and they can't afford to pay it. Right. So they have this fictitious list, and then they negotiate with the companies, the insurance companies. And then Medicare comes in and says, well, this is what we're going to pay. Now, almost every hospital in the country, there are a few, especially rural hospitals and safety net hospitals that, not necessarily true, but it's true of almost every hospital in the country, makes a profit, covers their costs, and makes a little surplus on Medicare rates. The reason they can charge 22% less, well, actually 16% less if you're going in that direction, Medicare can reimburse at 16% less, is because than private insurance, is that Medicare is cheaper for the hospitals to bill. That difference, that 16% difference, is made up with the billing and insurance-related, excess billing and insurance-related activities that hospitals have to incur to bill and negotiate with private insurance. So we do away with the private insurance. We give them Medicare rates. I debated Zeke Emanuel, who I taught with Zeke years ago at Harvard, a social theory course. And, he was like, Medicare rates are ridiculous, Well, okay, maybe we have to adjust them, and CMS is understaffed and there's too much fraud. Well, okay, so maybe we have to have a little bit more than 1.6%. I actually put in 2% over here for administrative expense. But you do all that, and you do away with billing insurance-related expenses, and hospitals can deal with Medicare rates. And that's what they would be getting, which instead of the $16,000, it would be $14,500. And that's where we're getting the savings, by getting those Medicare rates in and getting rid of the billing costs.
David.
David McClanahan.
My host last time.
I noticed that much of the resources come from federal monies. Mm-hmm. I'm wondering if this plan can be implemented gradually while the waivers for federal monies are obtained, hopefully in the next election or the election after that, so that the Medicare and Indian Health Service essentially the VA and the whole ERISA things. Can this plan be started to be implemented?
Yes, it can be implemented. Now, we're not touching the Indian Health Service and we're not touching VA. Those are funds that come in and they go out. They're unchanged. There are two major issues here that require waivers. The first is Medicare. And I would be very aggressive, and your senators should be very aggressive properly on this. Medicare, you file for a Medicare Advantage plan that would be covered by the state. Every sane person on Medicare would sign up for this because it would take care of the Medicare Part B premiums and they would get 100% first dollar coverage. So it's, and they don't need a separate Medicare Part D. So it's a true complete coverage. And so the Fed funds go into that and that's it. Medicaid, the feds have been very open about all sorts of Medicaid waivers. There are 150 or so operating in the 50 states. Maybe more. I think that's the number. But don't quote me on it because I'm not 100% sure. The Medicaid waivers have been very generous. They give them, all you have to do is make the claim that your Medicaid program will actually have equal or better coverage than the current system. Yeah. And they get away with all sorts of stuff. Indiana's putting in work requirements. Turns out those work requirements are going to cost Indiana like $2 billion to implement. Yes. It's just punitive. But okay. So I think you go in, you say, okay, give us this, and we'll put everybody on Medicaid in the state into a state HMO, and we'll operate as part of the broader system. And the feds have no reason to turn it down because it will save them money over time by controlling healthcare costs in the state.
Dan.
Yeah, quick question about, and you may have said this, I don't know if I missed it. In my case, my whole career, I've gotten my health benefits, through employer, probably like a lot of other people. What I want to know is, would this, if we enacted this, how would that change for employers? In fact, they use it for recruiting. Yes. We have really good benefits.
Yes.
And if you lose your job or you want to change your job, you could be in trouble. So. Does this take them out of the picture entirely, or are they involved still? And if so, how?
It takes employers completely out of the system. So your employer will be paying the tax, but nothing else. Woo-hoo! They won't be negotiating with insurance companies. They won't be dealing with insurance companies. For employers, this will mean they won't be able to use healthcare as a recruiting. That's good for small employers, bad for big employers. Even small, for everybody, they won't lose their health insurance when they change jobs or lose their job. That will be really good for millennials and others, even older people who want to start out on their own. I mean, there's some 62-year-olds who might want to leave their teaching position and start a consulting firm. Not me. But now they may be held back by fear of losing health insurance. Changing jobs. You change jobs in America these days, you change doctors. I mean, that is so... one thing that is universally accepted, I think, in the medical literature is a good relationship between the patient and the doctor helps healing. Well, so what do? Every year, your insurance company negotiates a new network. You have to change doctors. You change your job, you change your insurance, you have to change doctors. It doesn't make any, it's bad health practice. Yeah.
Kathleen here in the back.
We just saw a piece of legislation that changed the tax code that was supposed to benefit all of us. And what really happened is that it's benefiting the people at the top of the food chain. And so consequently, I want to be sure that if we implement this program in Washington, that there is some way that employers who will be getting a huge reduction in the amount that they pay for health care for their employees, get it back to the employees.
Well,
There should be some percentage.
That's a very good point. Health economists, labor economists, as I said, will all agree that, oh, you're already paying for that. So it should automatically come back to you. That's not necessarily going to happen. And in my work for Bernie, I actually assumed it would take 10 years to work down, 10 years of slow wage increases to eat up those to get to the point where workers get all the health premiums back. There could be legislation put in that would require some sort of payback. I don't know, but you've got a very good point, and it's something that I think the whole Washington people should really be thinking about as they go forward.
We're going to need something to do in 2020, Kathleen, so that'll be our project.
Yeah.
I am Chris Knazer, and when I've been taking this petition around, I've been asked, what about getting health care if you're outside the state of Washington or outside of the country?
That's a good point. And there are border issues. People coming in from outside. Now, the current practice for countries like Israel, where my pseudo son-in-law is from, Israel buys travelers insurance for its citizens in the United States. The whole Washington board will probably have to do something like that. And then there are people who come in from out of state, and there'll have to be some billing system set up to bill them. Or maybe not. Maybe you just treat them the way the National Health Service does. I got hit by a car. I told you I'm an idiot. I got hit by a car the first time I was in London. Now, you notice if you go to London now, at all the crosswalks, they paint in, look left or right, whatever the right way to do it is. They tell you to look. I didn't. I looked like I was crossing a street in New York. Because, New York is the world, right? Yeah. Well, anyway, so of course I got clipped by a car. Now, being a typical 24-year-old or 23-year-old male, I was like, oh, I'm still alive, But my girlfriend made me go to the health service where they did an X-ray and they gave me ice and all that stuff. And they said, you'll be okay, but just be more careful. And I said, okay, how do I pay? And he said, this is the National Health Service. And I was like, okay, but I know I can read, but, and I know your accent, but, how do I pay? I'm not British. Don't you charge me? He said, no, we don't have any way to charge. Wow. It's like my daughter, I did a sabbatical, and of course, when my daughter graduated college, we had to buy her a plane ticket to visit us in Rome. And we took her up to Florence because, you gotta. And of course, and she got sick. So we ended up, my wife took her to the hospital, the oldest hospital in Western Europe that's been in continuous operation. And they had a beautiful Fra Angelico mural there. It's very real. You go to Florence, you get treated right. Okay, my wife wanted to pay. And she waved her credit card at a nurse. And the nurse said, Italian hospital, no charge, not like America.
Marcia, here in the back.
Hi. You mentioned 8.5% payroll tax for employers.
Mm-hmm.
And I'm curious about independent, self-employed people and individuals who might have set up LLCs for small businesses, or small businesses who might just have a few employees. What would the...
Well, there are several different things there. If you're in a partnership or self-employed, then your profits, whatever you call it, whether you pay yourself a wage or a salary, or you take it all out in profits, or whatever, you pay 8.5% just like it's wages. If you employ a couple people, then you pay 8.5% on their wages and salaries. So all forms of income coming from business will be taxed at the same rate, 8.5%.
Joe, back here.
Hi. The question I want to ask is that one of the concerns I always hear about when talking about single-payer healthcare to more skeptical people is they're always referring to countries like Canada and about their wait times. And then I saw recently, actually on the CBC channel, when political parties were vying for votes for their election, the NDP party was talking about that if you went and vote for one of their candidates, they would help reduce, plan to help reduce the wait times up in Canada. I want to know what your response was to that.
Okay, that's a very good question. Wait times in Canada, that is an issue that you're going to be hammered on. There are a couple things there. First of all, it's mostly a myth. I mean, there are serious analyses comparing wait times. First of all, we have wait times here. You know, we have wait times for people who can never go at all. You know, but the wait times for people who actually get the services, important services, essential services, there's virtually no wait time in Canada or Great Britain. You show up at the hospital with, with some serious condition, they take you in right away. You have something you really need right away, you get taken. There can be wait times in Britain, Canada, and other countries for optional services. For services that you don't need right away, and then you get in line. Now, how long is that line? Well, my phone just had an opinion. How long is the line? The line depends on the resources that we put into the hospitals and the operating rooms and the physicians, etc. The politician and the NDP guy, I suspect he was saying we should spend some more on the health service. In Britain, which has a very cheap health service, they spend about a third what we spend. They need to spend more. And the Labour Party, when it was in power under Tony Blair, no comment. But on this, I mean, they really were trying to put some more resources into the health service to lower the wait times on these optional services. So you could get your knee replaced sooner. But we have wait times now, and in the United States, and they're for some things they're better, but for many things they're worse than what goes on now in Canada. Now, there's one other point about Canada. They say, people cross the border to get services in the United States. Oh no, they cross the border to get services in Canada. There's been study at the immigration points, the crossing points, in Minnesota, in Michigan, in Vermont, and there are a lot of people who cross from the United States to go to Canada to get services and to buy pharmaceuticals. There are very few people who go from Canada to here. There's good reason. Okay. Anyway, who's next?
Chuck, here in the back.
Thank you. Thank you, Dr. Friedman, for your study. It's really going to be very helpful. You were talking about, I think it was like transitional costs on a pie chart.
Yeah.
I'm not sure which one it was.
Yeah. Yeah.
But I know that in Colorado, we heard that one of the challenges was the day after their campaign started, the Chamber of Commerce got on the air and repeated for weeks, all through the campaign, you're going to have to pay $25 billion in the next 10 years if you vote for this proposal. What does this chart show us, and how do we answer that question? We would really love to know.
Okay, the $25 billion, I imagine, is, well, here it would be $29 billion. I imagine what they were talking about is this is how much you'll be paying in taxes. Over 10 years, under this plan, you'll pay $330 billion in taxes or something like that. Sounds like a horrible number. How much would you be paying for health insurance premiums under the current system? I can't give you that number off the top of my head. I'd work it out on my computer. I have it there. It's probably $400 billion. Yeah. It's not This is the savings. This is the pie chart that gives you how much you'll save each year. Well, save in 2019.
I bet they won't use that one.
No. They don't want to see that one. Yeah.
Okay.
Now keep in mind, they're going to say, oh, you're going to pay all this in taxes. Well, you know what? Your health insurance premiums are a tax. It's just assessed by private companies. And it's a bigger tax and a less fair tax than we're talking about here.
Catherine.
Is there a comparison to the work that was done in Vermont?
The Green Mountain Care Board in Vermont, when it came out with this report, I studied it. I had nothing to do with Vermont on any side. And I've had nothing to do with California either. That's been Bob Poland. His study is pretty good. But the Vermont, they made conservative assumptions about the savings they would get from administration. They assumed fewer savings than I have. They assumed more increase in utilization than I'm assuming. They may be right about that. I think they're wrong about administration. They assume less savings from drug purchasing than I have. So they came up with a smaller number of savings and a bigger number for increased expense. And at the end of the day, they were still assuming that Vermont would be saving money. The reason they didn't do it was politics, because the governor was scared of the 11.5% payroll tax. Why did they have an 11.5% payroll tax? Well, I'm saying you could do it with 8.5%. Vermont is a poor state. Second, they're assuming fewer savings and more costs. Third, they weren't taxing capital income. So that's the difference between here and Vermont, in kind of a summary. Yeah.
Elise?
Physician supply question. There's currently Patient Protection for Affordable Care Act that privilege people who go into primary care. Is there any contingency for that in this plan?
Nothing in my plan. The primary care provisions of the ACA lasted only 3 years, so that's over. They were hoping states would pick that up and continue to raise the reimbursements for primary care, but that didn't happen. I think the board, as it works through its pricing, I think that they should change the current price list. I'm assuming they just do what Medicare does, but I think they should raise the rates for primary care. On the other hand, I don't want to go around saying that. It's like I don't have any specific ideas there. There are people who know more than me, and I hope that you will listen to them when you enact this and set up that board.
So I recognize that few of us still have questions that haven't been asked or answered, but we're going to close up, and so perhaps after we're done, Dr. Friedman can answer a few more questions.
And I also have my card. You can write to me.
Before we close up, we will ask him to get a copy. I think we have it. Can we post your slides on our Facebook page?
Oh, sure.
So we'll post those to the event so you can find them. But before we close, I'd like to let Sally Soriano be our last question asker. She's been a champion in our state for many, many years for universal health care.
My question is, Washington State has the most regressive state tax in the United States.
Hear, hear.
And how will this add, when you talk about taxing people at $15,000, it sounds like it might be more regressive, and will the board be able to adjust that?
The board will be able to adjust and will have to adjust, because I'm sure that as things go down, they're going to have to at least tweak the numbers that I have. I'm working on projections, and things never work out quite that way. But this is a mildly progressive tax, mildly. It's mildly progressive, and it's much more progressive than what currently goes on. Because what currently goes on is a lump sum, everybody pays the same amount, regardless of income. This is mildly progressive because the first 15,000 low-income people aren't paying. And then you continue up to 60,000 before you get the full 8.5% because of the way I structured the exemptions. Also, capital income is taxed. So it's much more progressive than what goes on now and is mildly progressive overall. I suspect that I don't know the tax system. You rely a lot on gross receipts tax and sales tax and property taxes, which all tend to be, regressive, yeah.
So before I turn this over to Vicki Rhodes from the whole Washington Board, please join me in a huge thank you very much to Dr. Friedman.
Thank you.
We are so grateful for his leadership, his good humor, and helping us make this a reality. So thank you very much. This will not be the last you've seen of him because we're going to get this on the ballot. So I'd like to introduce my friend Vicki Rhodes, who is one of the members of our Board of Whole Washington.
Hi. Just a real quick note here that in order to get this thing on the ballot, we need to print more petitions, and that is going to cost money.
Right here. Just put your mouth right off the screen.
So just right. Okay, I guess you can hear me now. So just a quick note that in order to print petitions and get out the vote and make sure that we get this thing on the ballot, we're going to have to ask for money. So we've got some ladies over here. There's Georgia right there with some donation envelopes. I believe, isn't there a red beret for donations?
We have red berets, 2 red berets for Medicare for All as an organization. Please look it up on Facebook and the World Wide Web.
Yes. And they have been working very hard on our behalf in the Tacoma area in particular. They've really been awesome. Oh, if you can raise your hand, Georgia will bring you the donation envelope.
So thank you so much, Vicki and Georgia and all the whole Washington people who are here. We're very grateful to you. If you haven't signed the initiative and you just want to do that much, there are a bunch of forms on the tables over here to your left. If you're ready to take an initiative with you and get 20 signatures, we can take care of that too. Go get it from that table. You need to return it to us at the P.O. box that's listed on the initiative. Please help your signers make sure that they actually sign the right box, put their name in the right box, put their address and their county. You would be shocked at how many intelligent people can't fill forms out. And each of these is gold. And if they get rejected by the Secretary of State, that's one signature that we aren't able to count in support of our efforts. So thank you so much. Next week, our guest will be Jason Ridreiser, who is running for Congress against Dino Rossi. He's one of the 3 main candidates in the 8th CD, and we welcome you to come listen to him about his campaign. Thank you.